My name is Tricia Castranio, and I am a program analyst at the National Institute of Environmental Health Sciences. I will be serving as your moderator today. By now, you should have the WebEx application running and should see the welcome slide on your screen. Because you will be muted throughout the webinar, please direct all questions, either technical or content related, using the Q&A box on the right side of your WebEx application. You are welcome to submit questions throughout the presentations, but note we will address the content-related questions only during the Q&A session. Again, please be sure you are using the Q&A feature and not the chat box. Keep in mind that only the panelists will be able to see your questions. The wider audience will not. Unfortunately, we may not have time to address all questions submitted today. However, following the webinar, we will provide a link to resources and contact information for our speakers so you may reach out directly to them. As a reminder, today's webinar will be recorded. I would now like to introduce today's panel moderator, Dr. Thomas Kirsch. Dr. Kirsch is the Director of the National Center for Disaster Medicine and Public Health and a Professor of Military and Emergency Medicine at the Uniformed Services University of the Health Sciences. He is a board-certified emergency physician and expert in disaster management and science, austere medicine, and healthcare management. He comes to NCD-MPH from Johns Hopkins University, where he was a professor of medicine, public health, and engineering. He has real experience in disasters and humanitarian emergencies and has responded to events in the U.S., including Hurricane Katrina and Sandy, as well as the 9/11 terror attacks in New York City. He has also responded to global disasters such as the earthquakes in Haiti, Chile, and New Zealand, the floods in Pakistan, and Typhoon Haiyan in the Philippines. Tom, the floor is yours.
And greetings to everyone who has joined. Welcome to the second of our online series of our online webinars in this series. These webinars are part of a larger effort whose ultimate goal is to help create a more resilient healthcare system in the face of increasingly severe natural disasters. The project is a collaboration between my center, the National Center for Disaster Medicine and Public Health, the National Institute of Environmental Health Sciences, and the National Institute of Standards and Technology. We are working with other federal agencies to improve the science of healthcare system response modeling for natural disasters using integrated approaches. The first webinar was last week and focused on the current state of the science in predicting healthcare system responses to disasters. During that webinar, all of the speakers emphasized the need for more and better data to build more accurate models. Dr. Hupert described this as the need for modelers to work elbow to elbow with responders and other scientists. This seminar will take more of that responder view and will focus on the current approaches to decision-making regarding healthcare system preparedness and identifying unmet scientific and analytic needs. The delivery of healthcare is the final part of critical infrastructure needed to respond to disasters, but not as much focus has been spent on it as other critical infrastructure areas. Our goals are to build understanding of critical tipping points in the vulnerability of current health systems, including the buildings, infrastructure, operations, and the human staff, to build an evidence base for specific risk mitigation measures. Building on the two webinars, we are holding a closed conference for federal program staff to define shared priorities and to start to build a roadmap for scientific endeavors in the field. We then hope to hold a broader conference of government and academics to identify the specific needs, targets, and priorities to improve healthcare system preparedness using integrated modeling. We're very fortunate today to have an outstanding set of speakers, each addressing some of the practical implications of healthcare system modeling from a federal to a very local perspective. Each of our speakers will give brief presentations, and then we will turn to questions from you provided through the WebEx system. So don't forget to type in your questions for us, and we'll be collecting them through the event. I would like now to introduce our first two presenters who are presenting in tandem. They will jointly provide you with a federal disaster management perspective, Jamie Rome and Michael Sharon. Jamie Rome is a storm surge specialist and team lead at NOAA's National Hurricane Center in Miami, Florida, and is the NOAA representative for the Tri-Agency National Hurricane Program, which also includes FEMA and the Army Corps of Engineers. Mr. Rome oversees the National Hurricane Center Storm Surge Unit, which produces official storm surge forecasts during tropical cyclone threats to the United States. He served as a science policy advisor in the White House Office of Science and Technology Policy with the Bush and Obama administrations in 2008 and 2009. Mr. Rome received the 2016 National Weather Service Isaac Klein Award and the 2017 Department of Commerce Gold Medal for his work in developing storm surge forecasts and warning systems. He received both his bachelor's and his Master's of Science degrees in meteorology at North Carolina State University. Jamie, the floor is yours.
Good morning. Just want to confirm that the audio is working.
I hear you well, Jamie. Go ahead.
All right. And then is the screen up and live?
We have a slide of the speaker showing right now. If you want to try to advance, we'll see what happens.
All right. So the first slide should say Hurricane Community Preparedness, and then it would be like my name and title.
Jamie, I think we need you to share your screen with all of us.
Okay. It's not. I don't have the little button that says share your screen. Well, I can do a quick introduction while we're sort of simultaneously working on that. I'll be talking to you today from the perspective of my work over almost 20 years in the trenches at the National Hurricane Center, working disasters from a forecasting and warning perspective, and talk to you about some of the things I have seen over the course of those storms. We've always wanted to engage the healthcare community, so we really appreciate this opportunity. And the reason we wanted to engage the healthcare community is that, you know, I've seen over the course of several storms these gaps in data and understanding that I think we could, if we could get at these gaps, we could really start to move the needle a little bit on making our healthcare systems a bit more resilient. And I'm guessing the screen still hasn't come up, right?
Correct.
If someone just tell me where the button is, you little button that comes up that says share your screen, it's not come up yet.
You should see a share option at the top of your WebEx.
Oh, here we go. We found it. It's embedded in this little thing. How about now?
Yes, we see your desktop.
Oh, all right. There we go. So, all right. So we've sort of got through this initial slide here. These are some shots from this past hurricane season, if you're sort of interested in what it looks like inside the hurricane center. Now, before I get to the crux of the matter here, I just wanted to speak to a lot of the misconceptions that we are seeing with respect to cyclones. If you look historically over the last several decades, specifically from 1963 to 2012, and you look at the causes of direct death, these are direct deaths. So let's suspend for the moment indirect deaths and speak solely about direct deaths. And then you look at attribution. Almost 50% of the lives lost historically are due to storm surge. That's salt water. Another quarter are due to rain or freshwater flooding, and then there are a few due to surf and these sorts of things. The bottom line is a vast majority of the lives lost in hurricanes are from water, not wind. And how many of you actually knew that? Now, since this is a virtual meeting, nobody's going to see you raise your hand, so be honest with yourself. How many of you actually knew that it's water that kills people, not wind? My guess is, based off speaking to other sectors, that's a surprising statistic. Now, there's another surprising statistic that I need to walk you through. This is looking at New York City, New Jersey area. Let's focus on just New York. These are the evacuation zones for that area. So they're in this part of the country, in this area, they're called 1, 2, 3, 4, 5, 6. These are the populations that are associated with these preset zones. These are set before a hurricane. And now I'm going to show you some storm surge modeling results that we provided the officials in the preparedness of these zones. And if you look, they almost match match up perfectly. And the reason I did this little simple exercise is to prove to you that we evacuate in this nation because of storm surge, not wind. Evacuation in this nation is due to storm surge, except in areas that are vulnerable to wind, meaning buildings that are not engineered to sustained winds of that magnitude. But by and large, evacuation in this nation from hurricanes is a function of storm surge. How many of you knew that? Now again, since it's a virtual meeting, nobody's going to see you, you can be honest with yourself. If history is any guide here, most people find that shocking or enlightening, that we don't generally evacuate for wind. And so with that, that helps me sort of bridge into what I've sort of seen over the course of many, many storms is what little bit of engagement I have during a storm with the healthcare industry. It feels like there's a lot of misunderstanding. People are trying to get at data and information that either doesn't exist, or it's very hard to find, or it requires an expert to assist with the interpretation of that information. And this is really impeding, I think, the types of decisions that need to be made in the healthcare industry, both before and during a storm, to make those facilities more resilient. So with that, I want to sort of briefly introduce you to what we do here at the National Hurricane Center, because I think I have some hope to offer you. So the Hurricane Center, in addition to doing what you know, which is forecasting and warnings during an actual event, we have this huge mission that people just don't quite know about, which is we support coastal community preparedness and resiliency through vulnerability modeling and mapping. And so very few people know this outside of FEMA. FEMA actually funds a good chunk of this work, and we actually get the mandate for this work via the Stafford Act. So FEMA really is, we're attached to the hip with FEMA on this. And we've done it historically to drive these evacuation zones and the associated planning that I just walked you through. But we're finding more and more and more applications and need for this vulnerability mapping. And I promise I'm going to make this less abstract in a second. But just for the moment, if I could just get you to understand that we do more than forecast and warnings. We also do a ton of outreach and education, which I think is a huge opportunity for partnership with the healthcare industry to start talking about how to bring down our mortality from hurricanes. And then we do what you all know we do, which is provide accurate real-time storm surge forecasts during a hurricane event. We also have a ton of visibility. We get a lot of people who come through here, and this case, Obama was here. For his annual, the president gets an annual hurricane readiness briefing, and he did this particular one here at the National Hurricane Center. All right, so cutting to the chase, this is the nation's vulnerability to storm surge. So this looks like a lot in front of you, but basically everything that is colored in this map is within arm's length of the ocean. So let me explain that. We've gone through and modeled worst case analysis. So think about the worst imaginable hurricane hitting the coastline. We've gone through and modeled it for all locations and then mapped it on one big map here. So it enables for the first time, this is relatively new data, so if you've never seen this, don't feel bad, it's relatively new. For the first time, we now know the nation's vulnerability to storm surge. We've also done CONUS. So here's CONUS, the Puerto Rico, Virgin Islands, and Hawaii. So you can see the vulnerability of these areas as well. I put this in here because I know this is a topic on everyone's mind, so I inserted that there as well. Now what's interesting here, and I apologize, I don't know much about hospitals and your data, so if I butcher this up, this is just to hopefully show a possible application. This is Miami, so this is where I'm right here, speaking to you live from right here. If we were to take this vulnerability map and sort of overlay it with hospitals, one can immediately see vulnerability. Obviously, vulnerability is far more sophisticated than this map, but it helps to take that earlier bullet and make it less abstract. So that was the whole point of this, is I think the data is now there for our communities to start engaging and closing that gap. And if you look in here, you can look at vulnerability under different scenarios. So this is a worst case category 1 hurricane, worst case category 2 hurricane, worst case category 3 hurricane. And what you can see is that hospitals are wet in some scenarios and not wet in other scenarios. So it can help you to start understanding not only vulnerability, but maybe moving towards mitigation and planning. For example, maybe a generator needs to be lifted up off the ground to make it more resilient to flooding. And so I just turned the colors here, different color, to help show hospitals that are in and out under different scenarios. This is a case of Charleston, for those that didn't know. So Charleston, this is downtown Charleston. Charleston, the South Carolina area is one of the most vulnerable areas of the country. There's a reason it's called the low country. It's low. It has no elevation, really. And you can see the flooding potential which occurs in different scenarios. And really shockingly, look at this worst case category 5, where you basically potentially taken offline several hospitals that would be critically needed in a disaster of this scale. So it really helps you to start see vulnerability and better yet, plan for it. Now, out of respect for my 10 minutes and the other speakers, I'm going to end there and hand it back.
Thank you, Jamie. That was a great introduction to NOAA's storm surge work. Just a reminder for the audience, don't forget to type in your questions. We're going to compile them and we'll get to them at the end. But let's go ahead with our next speaker. Our next speaker is Michael Sharon. He's the Federal Preparedness Coordinator for FEMA Region 3 and has been an emergency manager for over 24 years. Just for your information, FEMA Region 3 is the Mid-Atlantic area, which is near and dear to my heart since I live there. That's Pennsylvania, Maryland, Delaware, the District of Columbia, Virginia, and West Virginia. Mike oversees the region's emergency training, exercises, continuity of operations, hazard risk and risk identification, and the National Incident Management System, or NIMS. Mike has tremendous real disaster experience, having responded to numerous emergency events throughout his emergency management career with FEMA, the Department of State, and with the Maryland Emergency Management Agency. Mike, the floor is yours.
Tom, thanks very much for that introduction. So what I'm going to do today is talk about, build off of what Jamie talked about at a very localized and specific level, and talk a little bit more from an emergency management and community perspective about some of the models that we use, but in addition to the models, some of the data that we use in the emergency management community before, during, and after disasters to support our decision-making responsibilities. So I've broken this out. I'm going to talk about applications of modeling and data across the spectrum. Right now, we use a variety of different models, and these are not all inclusive. There are many of them that are out there, but I wanted to show you some of the tools that we use in the preparedness and mitigation phases for community preparedness and community mitigation, and talk a little bit about what some of those applications are. So we're looking at things like, as Tom mentioned, threat and hazard identification. And so for a hospital community, Jamie talked about storm surge, but looking at models that could impact, are you located in a floodplain? Are you in what's known as, we classically call a 100-year floodplain or a special flood hazard area, but that doesn't mean a flood will only happen once every 100 years. It's a 1% chance on an annual basis. We use these models to look at some of the potential community impacts. Empower, one of the data source provided by the Center for Medicare and Medicaid Services, gives us a snapshot of where we may have populations in a community that are dependent on electricity for important medical equipment. We can target our needs and look at infrastructure interdependencies. So we work with the National Infrastructure Modeling Center, or NISAC, to see how power, water, other types of infrastructure may interrelate and how the failure of one may impact some of the others. And so some of the other models that we use up here, we also look at dispersion models. While we're focused on natural hazards here today, I want to take a little bit of an all hazards approach, and I'll show you some outputs of these in a later slide. But we look at, if you have a nearby chemical facility, what could some of those impacts be? Do you need to be worried about a downwind hazard from a likely scenario? Again, talking about risk map and the potential for flood hazard mitigation in your area. What are the localized riverine or lake-type flooding that may impact a facility or a community. We certainly use a lot of the National Weather Service products as inputs or data sources to drive some of these models, but we use their storm surge modeling as well. We use generalized ETE, it's the one there on the lower left, evacuation time estimates, so that we get an idea if we have to evacuate a community, how long that will take. And I'm going to talk a little bit about a model that we use called HEREVAC, which does support the evacuation decision support system that Jamie mentioned. And one of the key ones that we use for the earthquake, hurricane, flooding, and now tsunami hazards is a FEMA model known as HAZUS, which enables us to simulate a particular disaster for a community and get a sense of what the infrastructure impacts might be, the amount of debris, potential for casualties, and things like that, to plan ahead and help build our emergency plans and try and address some of those vulnerabilities in a community aspect. So for our hospital folks that are out there, the best way to tap into a lot of this information is certainly a lot of really good hospital preparedness systems, but your local emergency managers, your state emergency managers are the ones that are working with these models on a regular basis. So if bad things happen, I break it basically into notice and no notice events, and I want to talk a little bit about how we use models and data to support our decision making when an event has taken place. As I mentioned before, we partner very closely with the National Weather Service and use a lot of their inputs to drive our number of other models. So in the case of a no-notice impact, like an earthquake, let's say, for a natural hazard, would be an NWS input, but we would use information from that to potentially run a model in HAZUS to get a quick estimation of what some of our losses might be after an earthquake if we have the location and magnitude. We definitely use Weather Service information to help us model, to do dispersion modeling if we have a chemical facility that may be impacted, get an idea of what the downwind hazards might be, and also to help us model impacts within Empower so that we get a sense of what communities might be impacted and what specified health needs we may need to address out in a particular community for folks that are at home and are electrically dependent for their durable medical equipment. So it's a real challenge in a no-notice event because we don't have a lot of time. We may not have a lot of good information. So for both a notice and a no-notice event, we're looking to try and anticipate the initial impacts, what some of the specialized needs might be that we'll need to address, and get as better a handle as possible on situational assessment until we have the opportunity to get individuals out in the field and be able to verify. A more optimal situation, not that any disaster is optimal, is when we have a natural hazard event where we've got some warning. Flooding is a classic case, but probably the best example, tagging on to my Weather Service colleague, would be when we have a hurricane that's approaching. So we will build off of Jamie's information and the great forecast we get from the National Hurricane Center to plug those into HAZUS to, again, look at what the potential losses might be for a particular area once the storm track begins to narrow down. We're certainly looking at all those storm surge models that Jamie and company are producing to help us determine what some of the localized impacts may be. And then we're also looking into the models and using those inputs for a specific model that we use called HEREVAC, which gives us a tracking capability based on Weather Service data, but also gives us some evacuation decision support capabilities and determines when we need to make a decision or when our local officials need to make a decision about whether or not to do an activation. Similar to, you see Empower on there and kind of an elongated circle that we have there. That's another thing. We will be looking at Empower before a storm ever arrives so that we can start anticipating where we need to focus power restoration or where we may need to focus on delivery of commodities or services for an area that maybe we expect will be impacted by a power outage. So to show you a little more specifics, in the upper left of the screen, that's a little hard to see, but that's a sample of what a dispersion model looks like. So we could run that before an emergency, if we know we have a localized chemical facility or even something like a nuclear power plant, to anticipate what kind of a maximum scenario might be in areas that could be impacted on a likely scenario. But again, taking Weather Service data, if we have an emergency that's taking place after an event, we can do a quick model just to help support local officials in determining who we may need to evacuate, what facilities may be in that cone of impact that may need evacuation or additional support. And so while we're talking natural disasters, I put the dispersion model up there because many of you all will remember that in Texas after Hurricane Harvey, we had significant impacts down in the Beaumont area with some of the petrochemical facilities. And so that's kind of a second order effect of natural disasters, and that's why I kind of take the all hazards approach here, because we might start off with a hurricane or a tornado, and we might find ourselves having to deal with an unintended release from a chemical plant or a nuclear power facility. So they all kind of tie in together. Again, in the upper right-hand corner, that's a quick screen grab from Empower. A little hard to see, so I'll navigate you through it. I took it for Philadelphia. And to give you an idea, that if you see the darker shades of brown on that slide are the areas where we have more folks that, by zip code, that are electrically dependent for their medical type equipment. So we can look at this on a blue sky day and say, South Philadelphia, where I live, we probably have a lot of folks that have medical equipment that's going to be very reliant on getting their power back on, or finding alternate methods for oxygen generation or things like that. And so it gives us an idea by zip code and by numbers, and we can start planning. And you can do this at the zip code level up to the state level. It gives us a lot of capability, or after a disaster, we get a quick snapshot and we can layer in where the impacts are. You can even layer in weather service radar and a lot of other things. So it's a very, very powerful tool, and it's been a real boon to the emergency management community to be able to better support the health and medical needs that are out there before, during, and after a disaster. And then in the lower left, this one isn't nearly as pretty. It looks like a table, but that's a sample evacuation timing table that is generated by HEREVAC. Now, Jamie talked about the fact that, yeah, we really do evacuate for storm surge, because storm surge is the killer out on the coast. But one of the factors that drives when we do that evacuation are the arrival of tropical storm force winds. And so while we are looking at low-lying areas of concern, we need to make the decision for communities about evacuating before the tropical storm force winds arrive. And so the HEREVAC tool, in addition to a lot of other mapping and other kind of capabilities, helps local officials and state officials decide when they need to make that decision, very difficult decision to evacuate a community and move people to shelter or get them out of the area for protection. So just a snapshot there. Many other models that are out there. I didn't even try and pull in what some of the evacuation time estimates look like, but we're constantly looking at a number of data sources that are available to us to support our decision making. But it's not perfect, and certainly one of the things that we're trying to look at are where are some of our gaps and seams, and our moderators asked me to talk about that. Certainly from an emergency management perspective, one of the ongoing gaps we see is consistency between data sets and map layers. I think we're getting better on that, because ArcGIS is kind of the standard, and certainly in the federal community and with a lot of our state partners, we're getting better about having kind of common base maps, doing a better job of using platforms like the FEMA Geo platform, where we can share map layers into ArcGIS and share information around like that. And our partners in the Department of Homeland Security do a nice job on having standardized infrastructure layers that we can all use. I think a larger challenge continues to be what I call user-friendly platforms for localized applications. So I can show you some very sophisticated models, and at some of our larger states or some of our larger urban areas, you probably have analysts on staff who are very used to working with these kinds of models and are used to working with geographic information systems. But from my perspective, I've got an entire region, and it ranges from Philadelphia, Washington, D.C., Baltimore, all the way out to areas in central Pennsylvania where you may have a 1 or 2 person local emergency management staff, or just a few people in a 911 center. They may not have the hardware or the technical skills to be able to do a lot of sophisticated modeling. So the more user-friendly we can make the platforms, so the folks out there with limited resources can apply them, the better off we'll be. There continue to be challenges on the next bullet pertaining to infrastructure model integration. We certainly know that power, water, communications, a lot of these things are all interdependent. And we're getting better, I think, being able to, at a very large scale level, if you heard our last webinar, integrate a lot of those things through some of the national lab capabilities and some very sophisticated analysis. But as a sort of a follow-on to the second bullet, being able to present that in a user-friendly way, or make order out of the chaos, because there are a lot of interdependencies there that we want to try and address, and it's kind of tough to untangle what some of those are, or present that in a way to decision makers that's very actionable. And one of the challenges, the last challenge I'll talk to before I hand it back over to our moderator in emergency management, is the continued challenge that we have with what I call specificity versus security. So we can have a lot of great information, especially when it talks about infrastructure and infrastructure dependencies, but we constantly have the tug, certainly here on the federal side, of how much information can we really share, and how do we secure that information so that while we as providers and emergency managers are looking at some of these vulnerabilities, that we're not inadvertently exposing those vulnerabilities to someone who may want to take a hostile action and cause impacts in the community. As you know, it's important that we plan ahead, but it's always the challenge of how do we share this and how do we secure this so that somebody doesn't unintentionally go forth and use that information. So with that, Tom, if it's okay, I see 2 questions popped up that I'd be willing to address if you can give me a second to go ahead and talk about those in the chat panel.
We're trying to save the questions for the end to open it up to the group, but I've been writing them down, so can you hold on for a few minutes?
I'd be happy to. And so with that, that concludes my slides. I'll hand it back to you, Tom. Thanks very much.
Thanks, Mike. That was great. I actually learned a lot about how FEMA uses models and about some of the practical applications already being used. Both of these overviews were excellent. Don't forget, like Mike mentioned, that we're collecting questions. I'm making a list here. They're popping up on the screen for me. So please, if you want to submit a question, do so via the Q&A box at this time. I'd now like to introduce today's third presenter. Melissa Harvey is the Director of the Division of National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness Response at the U.S. Department of Health and Human Services. That's kind of a long title that says that she works for ASPR. In that position, she is responsible for developing and implementing policies and capabilities to improve the nation's overall healthcare preparedness, including the Hospital Preparedness Program Cooperative Agreement. Melissa led ASPR's domestic healthcare system response to Ebola, including the development of the new regional and tiered strategy for the nation's healthcare facilities. Prior to her work in the government, Ms. Harvey was the program manager of emergency management for the North Shore Long Island Jewish Healthcare Systems in New York and was an EMT in New York City. Best yet, from my perspective as an emergency physician, Melissa is an emergency department nurse, registered in the Commonwealth in Virginia. She attended Boston College, George Mason University, and Harvard University. Melissa, the floor is yours.
Hi. Good morning. Thanks so much for having me on this webinar. I'm looking forward to sharing with you a little bit about the Hospital Preparedness Program, and I'm going to take a little bit of a different tactic and talk a little bit about how modeling could be very helpful to us at the federal level with making decisions with regard to our program. We certainly use some models in terms of how to determine funding allocations to all the various different states and awardees that we fund, but that's a fairly boring topic. But there's a tremendous amount of ways that modeling could be really helpful to us on the kind of healthcare preparedness front, and I'd love to share some of those ideas with you. So moving to the first slide, I'm sure you've all seen disaster timelines before, so I'm not going to spend a whole lot of time on this. The ones highlighted in red are certainly the various amounts of kind of extreme weather events, at least recently. And as you'll see kind of from the right side of the timeline, we don't seem to be having any shortage of emergencies, and if anything, they seem to be happening more and more frequently, so this is an incredibly timely topic to be discussing right now. So for those who are not familiar with the Hospital Preparedness Program, I always say that our name is a little bit of a misnomer because we're not just about hospitals and we're not just about preparedness. We are about all of healthcare and about preparedness and response. But we are the only federal government funding source for healthcare delivery system preparedness and readiness in the entire U.S. government. We aim to really prepare the nation's healthcare system to save lives that exceed the day-to-day capacity of the routine health and emergency response systems. But we really do believe that you can't set up a separate structure for emergency response with regard to the healthcare system. You have to build off of the day-to-day systems that you have. So in other words, kind of rapidly discharging patients from hospitals on a day-to-day basis so you can actually do that on a more extreme scale during a large-scale emergency. We do this preparedness through what's called the development of healthcare coalitions. And these are regional coalitions inside of every state in the country that bring their healthcare system partners together, as well as public health departments, emergency management, and other community agencies, to make sure that together they're breaking down those competitive barriers that we know exist within healthcare, to be sure that the various differing priorities of each of those different healthcare entities can be served during an emergency. So really what these groups are they're groups that plan together. They respond together by sharing information with each other about the status of their facilities and healthcare systems on a day-to-day basis, and certainly during emergencies. And then they are at least aware of each other's resource needs, if not able to assist in meeting those needs. I like to give this example often because we often think that emergency management is the agency to turn to when you need a resource request filled during a disaster, and that's certainly part of the ESFH structure as well, because emergency management has to have visibility of the resources that are being used. But healthcare resources are really different than the resources that the public needs to be fulfilled during an emergency. We had a situation in one state where there was a large-scale telemetry outage in their hospitals, and they were in need of cardiac monitors, but they didn't need to evacuate their patients when their central telemetry went down. That's not something you can typically call up emergency management and ask them to bring you hundreds of cardiac monitors. That's something that you're going to have to get from the other healthcare facilities, and you have to have those partnerships ahead of an emergency, not being able to make them right when that need arises. We do certainly promote a sustained national focus on improving patient outcomes and minimizing the need for supplemental state and federal resources during emergencies. But I will say many of the recent disasters have just been so incredibly large that we recognize that our program, which is funded at $255 million a year, certainly can't be used for all of preparedness. That's really a needle in the haystack of healthcare system spending in this country, and certainly there will be a need for supplemental state resources during emergencies. So just for clarity about how our funding does flow, it goes from the federal government to 62 awardees. And those are the health departments at the state, local, and territorial department levels. And from there, it goes to 476 healthcare coalitions. And currently, inside of those coalitions, there are 31,000 members. And by members, I don't mean an individual person. Those are typically, again, different healthcare facilities or community agencies, governmental agencies that are part of those coalitions. We've just been moved to the Healthcare Coalition approach in 2012, so these are still very much, in some cases, in their infancy and developing across the board. There's varying degrees of Healthcare Coalition maturity, where some coordinate healthcare responses on behalf of the ESFH structure entirely on their own, and others are more right now just trying to figure out what their borders are, what their bylaws are. And that's where we say there's a potential to have nearly 75,000 coalition members in the coming years as more and more of these partners continue coming to the table. But again, that stresses the whole impact of efficiency. We have $255 million a year and potentially 72,000 different healthcare entities that need funding to be able to improve their readiness. So just for a graphical picture of what a healthcare coalition is, we consider there to be 4 core healthcare coalition members that must be part of all healthcare coalitions. 2 hospitals have to be a part of all coalitions because there's no one that you can really turn to in the healthcare side to provide you those resources that emergency management may not be able to if you don't have another hospital in your coalition. But certainly public health departments, emergency management agencies, and EMS are core members of coalitions that we feel must be at the table. And then every community has their own array of various different types of healthcare facilities that are just as important, but at the same time really are in a supportive role when it comes to medical surge so that we can keep some of that surge from coming to the hospitals. The other part of this is, again, not all of these different kinds of facilities that you see in black are part of every single community, and we didn't want to limit healthcare coalitions to only those communities that have some of these much more specialized kinds of services, and therefore that's why we call them more optional members, but we do recognize the really important role that they play. So again, as I mentioned, we have 31,000 healthcare coalition members and a bit of a ways to go in terms of getting complete saturation in healthcare coalition membership among the others. but we do have, for example, 85% of all hospitals in the country currently participating in healthcare coalitions. I'll leave you just to visit our website to see a little more about what we call the impact in the field of healthcare coalitions, but 3 recent events and planned events and emergencies that we have highlighted on our website are Hurricane Matthew and a Georgia Healthcare Coalition in terms of what they did as far as collaboration and informed decision-making before landfall in order to do a very seamless evacuation of patients. We're certainly working with the Houston Area Coalition to talk about some of the phenomenal work that they did during Hurricane Harvey, and that will soon be posted on our website as well. We have a story about the Fort Lauderdale airport shooting, which happened exactly a year ago, and there was a tremendous amount of coordination on site at the airport with the Broward County Healthcare Coalition in terms of even patient distribution throughout the coalition to make sure that all of those victims of that emergency were able to receive the life-saving care, including surgical resources that they needed, because we certainly would have inundated some of the even larger hospitals by sending all of those patients to one facility. And last but not least, the Republican National Convention. Just to emphasize again, healthcare coalitions don't need to be used only for responses to emergencies, but can be used for planning for large-scale events, including this weekend's Super Bowl and other types of mass-scale gatherings where there could be a potential need for a large-scale healthcare response. So on to modeling. I'm going to talk a little bit about one area where we feel modeling could have been incredibly helpful. And while this webinar does focus on extreme weather events, I wanted to highlight infectious diseases because we know that extreme weather events can actually cause a downhill impact on infectious disease outbreaks, even though certainly Ebola was not related to an extreme weather event. But at the same time, when we think about healthcare, a lot of what healthcare wants to know is what the surge is going to mean for them. What is the impact going to mean to a healthcare facility, to a healthcare coalition, to a state, and certainly for us, on the national and federal perspective, what is that outbreak going to mean? What is the size of it going to be? What types of resources do we need? When can we anticipate needing those resources? These are things that have to obviously be done through predictive modeling, and that's something that early on, even in the most imperfect of models that can be translated really well to individuals like myself who are not modelers, who do not work with data every day, but really could use some guidance on how to make some of our decisions could be incredibly helpful. So I'm just going to walk through this example very quickly. So in terms of Ebola, the way that the modeling worked for us was there was certainly a prediction of the outbreak speed that was going to be occurring in West Africa and resource estimates in West Africa, and based on that, an estimate of the importation of cases. But that actually came fairly late in the game, the estimate of importation of cases, where we already had to make some pretty critical decisions at the federal government level, which is why I emphasize the timeliness of modeling being incredibly important for us. To be able to put in our supplemental funding requests, which actually then turns into the strategy, because these requests have to be incredibly detailed about what you're going to do with the money, what areas of the country are going to receive the funding. We have to be able to have some of that information to put into that budget request, because that's the request, if it's approved and we're given those resources, that then has to be implemented. So while these emergencies unfold over time, we have to make these decisions often in the first week or two of a disaster that's unfolding. And one example I'll give is how we were going to achieve coverage for patients coming back from West Africa across the nation that could potentially have Ebola. What you see on the map on the left is in the green circles, which is where we had Ebola treatment centers. And you'll note that there was a tremendous amount. We had 55 of those at the time that this map was created, but they were very much congregated along the East Coast and in some of the major metropolitan areas in the Midwest, the South, and on the West Coast. But all of those areas that you see in red were completely not covered within a 250-mile radius of having an Ebola treatment center, and that's what we used, that 250-mile radius as the kind of outward bound for what you would want to do for a ground transport of a patient. And this really created a challenge for us because we were seeing patients under investigation all throughout the nation, including in Alaska, and we didn't have a place that we'd be able to send any of those patients to, not just because of geography, but also because some of those hospitals inside of those green circles said that they would only care for a patient that came from within their state, but not one that was being flown from outside of their state. So what we wound up ultimately settling on was using the current HHS FEMA regions, which you see on the map on the right, with the borders on the right, to create one regional center for each HHS region. Now I will say the HHS regions and FEMA regions are not perfect at all. Currently Region 2 includes New York, New Jersey, the Virgin Islands, and Puerto Rico. So trying to put one regional infectious disease center in that region, as just an extreme example, is incredibly challenging and probably doesn't make the most of sense. But in the absence of modeling, we had to move forward with a decision on regional coverage, and that's how we did it. So I hope that explains some of how modeling could be helpful to us in an infectious disease outbreak. But in terms of all hazards modeling, some things that the healthcare and medical institutions need to take into consideration are things, and some of this has come up already, but physical infrastructure and human infrastructure, the natural and biological phenomena of the actual hazard, whether that's a storm or an infectious disease outbreak. I mentioned a lot about resources, physical resources, materials, supplies, the impact on supply chain and where those interruptions could be seen, as we recently saw with Puerto Rico and the pharmaceutical manufacturing that was disrupted from Hurricane Maria and Irma. That's something that is incredibly important to model so that we can predict what the downstream effects will be for a prolonged period of time. Also, transport resources and how that could impact, even if the suppliers are there and the manufacturers are there, the distribution can certainly be a problem. One thing that's certainly unique to our area is healthcare market forces and the competition that exists between them, including the willingness to share resources and various other pieces that others have already spoken about, such as the financial and economic factors, the governmental and political influences, and the human behavior. Just with regard to what we're seeing with the seasonal influenza this year being particularly strong, and some individuals being resistant to not only vaccine but taking Tamiflu because of the perceived, because of the perception that the side effects of Tamiflu outweigh the risks, the benefits of taking it, which certainly we don't agree with here from HHS's perspective. The last thing I want to get into is, again, how modeling could be helpful from us at the federal government in terms of making decisions on funding. And this is an incredible challenge for us when we're talking about a program that funds broad healthcare system readiness for emergencies. We often are asked by our stakeholders and our funders, such as OMB and Congress, well, if we gave you hundreds of millions of more dollars, what would that do? What would it buy us? What is something concrete and tangible that you can tell us you would be able to do at the end of distributing that funding and having it implemented that would create better preparedness? And typically that's really, really difficult. It's not like those of you who are familiar with our countermeasures division, BARDA, where oftentimes when they're given that exact same question of what would you do with hundreds of millions more dollars, they can say, well, we would purchase X amount of a certain vaccine or a countermeasure, and that would give you Y percentage of population protection across the country. We can't really do that as well when it comes to just broad healthcare system preparedness. So we've thought a lot about an example from the NIH where they use the Biomedical Research and Development Price Index to measure how the NIH budget has to change in order to maintain its purchasing power. And it provides them with concrete data to justify their budgetary changes every single year to support their mission. So we're wondering if predictive modeling could play a role in monitoring preparedness needs and quantifying an economic return that we might be able to achieve with additional funding. So, for example, supporting all hazards preparedness by providing, substantive budget and policy changes and data-driven decision-making that could come from further investment, financial investment in preparedness. So we're not kind of left answering that question of, well, it would purchase us more healthcare system preparedness and readiness. And that's something that I'll leave to those of you who are modelers on the phone We're happy to talk with you further about, our challenges and needs in this area, but would really love to spark a discussion on how we can quantify using modeling economic returns in healthcare system preparedness. So with that, that's the end of my presentation. I know we're not taking questions now, but I'll turn it back to you, Tom.
Thank you, Melissa. That was great. It really sounds like the Hospital Preparedness Program has a critical role to play in strengthening the healthcare system critical infrastructure, and I'm glad to hear the efforts are put in there. Don't forget that if you have any questions for Melissa, please submit them at this time. We're getting quite a few questions coming in. I'm compiling them, and we'll get to them as soon as possible. Let's turn to our next speaker, Dr. Kimberly Schoaf. Dr. Schoaf is a professor and associate chief of community engagement in the Division of Public Health within the Department of Family and Preventive Medicine at the University of Utah. Prior to joining the faculty of the University of Utah, she was the associate director of the UCLA Center for Public Health and Disasters. Her research encompasses the healthcare impacts of disasters as well as preparedness of the healthcare sector. In her early work on the casualty estimations of earthquakes, she brought high-quality epidemiologic methods to disaster research and was instrumental in the development of my career because of that, and my work on the impact of earthquakes on hospital functioning. In addition to research, Dr. Schoaf has worked with more than 50 local and state health departments in developing their emergency response plans, training their workforce on emergency public health, and developing and conducting exercises. Dr. Schoaf received her Bachelor's of Science in Health Education from the University of Utah, her Master's in Public Health, Population and Family Health from UCLA, and her Doctorate in Public Health and Community Health Sciences from UCLA. Kim, the floor is yours.
Worked with many local and state health departments over the years to be able to talk a little bit about what they do and how they work and how they can use models. So I first want to talk a little bit about, as Melissa's already talked about ESF 8 and the health and medical planning for functions. There are many partners that are involved in this, and as Melissa just showed you, the funding agencies are the local, state and local public health agencies, and then from there they engage the healthcare coalitions, which are made up of hospitals and long-term care facilities and primary care facilities, urgent care centers, and many other health providers, including the 16 provider types that Center for Medical Services, Center for Medicare and Medicaid Services have recently provided new guidelines in terms of their emergency preparedness. All of these partners are important as we start looking at how locals can use these various models. So as public health is the lead for ESF 8, this is from the list of all of the things that public health and the ESF 8 lead are responsible for a disaster. And highlighted in red here are some of the things that really, that modeling can truly help us in being able to do some of these things. Clearly, looking at the assessment of the public health and medical needs, we need to be able to have data to tell us what are the potentials for this, for any hazards that may occur. From ensuring that we have sufficient numbers of and the appropriate kinds of medical care personnel, equipment and supplies, decision-making about patient evacuation. When do we evacuate? Who do we evacuate? Where do we evacuate to? Somebody had a question earlier about evacuating hospitals and using the modeling to evacuate hospitals. And there's often the question, evacuating hospitals is not the same as evacuating communities and households. We need to look at, what are the risks of evacuating a hospital versus the risks of that hospital sheltering in place during a storm. And utilizing modeling can definitely help us with that. As well as patient care. What kinds of things do we need to have in terms of being able to care appropriately for the patients that are, both those that are in the hospital already or in our services, as well as those who may be coming in as a result of the disaster. So I want to talk a little bit about the public health needs for modeling at the local level, and then I'll talk a little bit about how do we use these things and how do we improve them in order to be able to, for state and local health departments and their planning partners to appropriately use models. Certainly when they need to plan for response needs. And all health departments are required by their CDC funding to conduct a hazard vulnerability assessment. And I'll talk in detail a little bit about the hazard vulnerability assessment that they need to do and what capacity they have to actually do that. They also need modeling for coordinating the health and medical response during an emergency and having models that would allow them to make decisions early in the process of the response efforts before they have actual data on the ground data for ground truthing. Having those models to be able to respond to those things quickly would greatly benefit their ability to coordinate those health and medical responses to an emergency. And then in terms of exercises and using models as a basis for conducting their exercises. So let's talk a little bit about estimating potential response needs for planning purposes and conducting a hazard vulnerability assessment. The capability one, so the FEP program, the Public Health Emergency Preparedness Program that's funded by CDC, which is the companion program to the HPP program that comes out of ASPR, they have capabilities for the state and local health departments to do. And the number one capability is community preparedness, and the first function of that is determine the potential risks to the health of the jurisdiction and basically doing a hazard vulnerability assessment. And when they look at that, they want the jurisdiction to be able to identify the potential hazards, vulnerabilities, and risks in the community that relate to the jurisdiction's public health, medical, and mental behavioral health systems, and the relationships of those risks to human impact, interruption of the public health, medical, and mental behavioral health services, and the impact of those risks on the jurisdiction's public health, medical, and mental behavioral health infrastructure. So that's a lot of things that they need to be able to look at. The wording in that capability comes directly from the hazard risk assessment instrument that we developed at UCLA early on in the FEP program. As a matter of fact, actually before FEP was actually FEP, the development of this instrument. And we looked at what were the kinds of things that the health system, public health and the health care system, would need to have in order to be able to know what it was that they were going to be capable of doing in an emergency, and what could a disaster do to those systems. This instrument was designed so that the local health department could gather information about their baseline capacity for these various components, and then estimate what the impact would be from a hazard, so that then they could see what their gap was between their baseline capacity and what kinds of things would be coming in from a disaster that would occur in their local jurisdiction. And we broke that down into human impact, interruption of the healthcare system, community impact, which is public health relevant, including things like water and transportation and utilities and population displacement, as well as an impact on the public health agency infrastructure itself. Excuse me. Local health departments, in conjunction with their planning partners, are able to identify these baseline measures. These are data points that are fairly readily available for the local health department to be able to do that. The problem comes when they get into the hazard-specific indicators. So how do they estimate what might be occurring in the variety of hazards that are relevant to their jurisdiction? So they need to calculate these same kinds of things for the different hazards that occur in their communities. One of the ways that they do that is they can utilize HAZUS, right? So HAZUS is, as was spoken earlier by our partner from FEMA. HAZUS exists. This is what has been out in the models, and I just noticed yesterday that there's the new tsunami model, and I don't know exactly what's in that. I'll have to take a look at that. But when we look at these various models in HAZUS, is very useful for emergency management purposes in general. But if you look down at the types of losses that are estimated, there is only one loss. There are two things really that are particularly relevant to healthcare and public health, and that is casualties and shelter needs. And casualties are only modeled in the earthquake module. There's a generic output for casualties in the flood model. It is very generic, and it's based primarily on motor vehicle accidents and the potential for drowning mostly from vehicles entering quick water in the area. There is no casualty module in the wind model. Shelter needs are also estimated, and that is something that that is important and useful for public health and healthcare, but mostly indirectly as they are supports to the mass carriage feeding function, ESF6. So the casualty module for earthquakes is the most robust of the modules, but it also has some significant issues. It estimates casualties only by building and bridge damage. It directly models casualties from structural damage, and also models non-structural casualties, but that's more a derived function from the structural damage. It does not include anything by any medical causes for casualties in an earthquake, car accidents, falls, power failure, incidents during post-earthquake search and rescue, cleanup, construction, electrocution, tsunami, landslides, liquefaction, et cetera, et cetera, et cetera. So it's a limited module, and it is comes up with estimates, and those estimates come in 4 categories, and the descriptions of those 4 categories are their severities 1 through 4, which are modeled in a way that it's very difficult for healthcare to be able to look at those. They are not directly related to types of service utilization. They are not directly related to any specific types of injuries. They are based on engineering models and not necessarily the most appropriate. If you look at up in the top right-hand corner, these are the injury classification scale, and in the bottom left-hand corner is a pyramid of different types of utilization, healthcare utilization, from injuries in the Northridge earthquake that we looked at. So we looked at those who were injured who did not receive any professional treatment, those who were treated out of the hospital, someplace other than in a hospital, treat and release from the emergency department, those who were hospitalized but did not require trauma-level care, trauma-level services, those who were admitted to the hospital but died while they were in the hospital, and those who died prior to receiving any medical treatment. Even that is a very broad characterization of what we might want to see in terms of injuries and how we can planning for those. At least from something like this, we could at least plan a magnitude of services, but not necessarily give us just enough information to be able to talk about what kinds of resources we might need in terms of bandaging or other types of bandages or IV solutions, or do we need medications? What are the things we need? So that's from a planning perspective, those are some of the things that we can think about. Just to say that most local jurisdictions do not have the kind of resources to even be able to run HAZUS. Certainly larger jurisdictions do. Smaller jurisdictions probably do not. But they do have, they may have mapping capabilities, but The HAZUS models, if they're it's a level 1 model, it's fairly generic, and it takes pretty sophisticated expertise to be able to utilize HAZUS at a much more in-depth and specialized, localized model. The next part is that to use modeling for just-in-time resource allocation. When we think about an event occurring, we look at doing some quick assessment of the health impacts. Certainly modeling can help us, can move us ahead in terms of what places we might want to look at, what are the areas that we should be thinking about, and trying to start requesting resources based on the models as opposed to based on local ground level data. We also do rapid assessments utilizing a CASPER, the Community Rapid Assessment Methodology, and can do that. But what types of resource needs can we have, and can models help us moving there in a more timely fashion? What levels of health impacts might we be seeing? What kinds of supplies or equipment might we need? How many bed nights might be estimated so that we can have that sort of thing available and quickly move people from hospitals to home or other places? As well as where do resources need to meet? Can we map this information in advance in the early hours of an emergency response? Oops, let me go back one. Just one example and that I've heard quite a bit in terms of working with some of the hospitals is thinking about, we need to plan for food and water for 4 days for our hospital in the event of an emergency. There's two problems with this. First is the 4-day myth. I'm glad that we went to 4 days from 3 days because 3 days had no validity, but 4 days is also a myth. We know that to get significant resources in a large-scale emergency, in a catastrophic event like Hurricane Katrina, we're looking at 4 to 7 days before significant resources are going to be flowing into a community. And so just that myth is the first thing. The second thing is in the planning, they often talk about, hospitals often think about the normal patient load, their personnel, but they need to think about surge capacity, what kind of surge are they going to see, and how about family members? So for every patient that comes in, how many family members might be accompanying them? And so to have that amount available in advance, or at least in the early hours of an emergency, would allow them to be able to respond in a much more timely fashion. The last area is exercises and utilizing modeling for exercises. And oftentimes when we think about exercises are often done and you use some sort of scenario. The question is, how realistic is the scenario? And is it scientifically valid? Is it something that is actually going to model what the potential hazard is actually going to do to the community? The U.S. Army uses the motto, train like you fight and fight like you train, which comes from this Miyamoto Musashi, who says you can only fight the way you practice. And it's really important that when we think about designing exercises for our hospitals, for our healthcare system, for our public health system, that they are fighting the way that they are training the way that they would need to fight in an emergency. And so utilizing models for this is also a very important component. And I think that is it. Thank you.
Thank you, Kim. That was a great overview of kind of the importance of local planning and modeling. At this time, I'd like to introduce our final speaker of the day, Katie Keeman. She's the program manager for emergency preparedness at Partners Healthcare System in Boston, Massachusetts. Since 2015, Ms. Keeman has served on the leadership team for Partners Healthcare's Strategic Resiliency Initiative, working to improve the resiliency to severe climatic and seismic events through facility and operations-based interventions. Katie has responded to numerous disasters throughout her career, including the 2009 H1N1 pandemic and the 2013 Boston Marathon bombing. She has published and presented on several aspects of healthcare system preparedness and response. Ms. Keenan received her BS in Public Health from George Washington University and an MBA from Simmons College School of Management. Katie, the floor is yours.
Great. Hi, everybody. Thank you for giving me the opportunity to speak during today's event. I thought I would talk a little bit about some of the data that would be useful from the healthcare private sector perspective, and also spend some time talking about that through the lens of the ongoing strategic resiliency initiative that the Partners Healthcare System is currently working on. So we're probably all familiar, but knowing that severe weather and climate change is going to have an impact on both healthcare demand and health in general. And some of the other speakers have already talked earlier today that, we're looking at caring for both the newly sick and injured, as well as the need to continue the routine healthcare services for all the patients that we already have. There is a lot that we can do within our property lines when we're looking at resiliency and preparing for these types of events. But we're also, in many cases, we're highly dependent upon the community infrastructure, whether that's utilities, transportation, our supply chain, and other healthcare organizations. So there are three ways that we have been thinking about approaching healthcare facility resiliency. The first is facility hardening. This is a picture of our Spalding Rehab Hospital that's built on the Boston waterfront, knowing that it is in a vulnerable location and building many resiliency attributes into the building design. So some of the things are installing flood barriers, moving utilities to higher levels, having operable windows so that we can allow fresh air if there are challenges with our air handling equipment, and lots of windows that will maximize natural light and reduce the strain on generators if we were without grid power. Another way is operational adaptation and planning. So this is our emergency planning or even changes over the long term to some of our healthcare operations where we might place services, where facility improvements are not really feasible, we will address it with a complementary operational initiative. And finally, joint advocacy, so working with city planners, with our healthcare coalitions and others on some of the anticipated changes in service demands that we expect to be facing. So I think a lot of the speakers have talked about some of this already in different ways, but there are certain data that would be helpful for us to understand because it helps us with both short-term and long-term planning, and I think that that's been a hallmark of the way we have been looking at this, is trying to look at both short-term immediate impacts to events and also long-term planning for changes in healthcare delivery and demands on our facilities. The first, Kimberly was just talking about the hazard vulnerability analyses that public health and healthcare organizations are required to do. The basic formula for that is risk equals probability times consequence. And without good data on what are the expected severe weather impacts, how long will they last, and what are the extreme limits of those, we don't have a good data to put into that formula, and we can't come up with a good measure of our true risk. I think some of the other we've talked about, facilities resilience, utilities, our dependency on public transit and operable roadways, both for our patients to get in, but also our staff and our supply chain. And then, the overall operations of the health systems. It's really critical because of how interdependent we all are. So, for example, if we are going to begin discharging patients in anticipation of a storm, is EMS able to be out on the road? Can home health absorb that surge and continue to see their patients during the severe weather, and so on and so forth. Some of the decisions that this impact data helps us with are decisions around altered clinical operations. So are we canceling elective procedures? You know, and alternately thinking outside of the hospital, you know, with our home health agency, how are they preparing to continue to see patients throughout the storm? Are they triaging appointments? Are they, you know, getting patients on specific regimens to get them through the storm? And then non-healthcare capabilities, those include, you know, things like being able to house staff and support them and their families during emergencies as well, and you know, conservation of supplies and making sure we have adequate equipment to get us through the storm. The next slide has just some information about the Partners Healthcare System, and I put it here for some context around the project that we've embarked on. So as an integrated health system, we're not only talking about hospitals, but a number of critical healthcare facilities and services. We are a fairly large organization. We have over 70,000 employees across all of our facilities. And we have been fortunate that our leadership has been on board with this, has allowed us, you know, to invest resources into this, you know, and we have also benefited from in-house expertise. We have engineers and architects who, you know, are managing 1,000-bed hospitals. And also the City of Boston and the City of Cambridge were already doing detailed climate modeling that we could build from when we began our work. So, you know, we are very fortunate as we look at this, but even so, we needed external expertise to help us understand our risks and know what to do about it. And so I think that's important when thinking about modeling across the country and who is going to be using information and what do they need. And I think, you know, others have talked about user friendliness, and I really think that that is key, because not everyone, you know, is going to be starting from the same point that we were fortunate to start from. There are still a few obstacles to getting started at looking at climate resiliency. In some cases, there's still skepticism about climate change and changing weather patterns. It is difficult sometimes to quantify the damage and business interruption. I think Melissa was mentioning that. And probably most importantly, and what has been a theme throughout, is balancing future climate projections and mitigation recommendations with all of the other very important and immediate capital budget requests that they are competing against. And I think you really have to strike the right tone and be balanced in how you're presenting data to decision makers, that there's a range of possible consequences, that there are potential business losses, but there are also potential gains in some of the things if we act. And, you know, we need to be reasonable in how we prioritize the initiatives that we want to put forward. And I think also sometimes our good emergency planning can almost hinder some of this work, because if we have good plans for continuity and sheltering in place, you know, we know that we have good insurance to cover, you know, building damage. You know, leaders will have to really look at, you know, some immediate needs that are there for serving patient needs today, you know, versus projected future needs, and they, you know, are difficult conversations to have. So the Partners Resiliency Initiative has been divided into 3 phases, and we're actually just getting started with the 3rd. So to begin, we conducted detailed climate modeling for 30 sites across our system for a range of scenarios that you see here, and we added in seismic since we were looking at so many other hazards, although we know it's not a climate change event. So, you know, everyone thinks about water and floods, especially being based in Boston, and we also have 2 island hospitals. And, you know, I think that that's certainly a concern, but some of the other vulnerabilities that we identified that I'm not sure all of our facilities managers were expecting were vulnerability to increasing wind speeds and the need to look at roofs and rooftop equipment, especially communications equipment and our reliance on IT systems in this day and age. And also the ability to maintain comfortable temperatures in our buildings as heat and power demands rise. In the second phase of the study, we used the HHS resiliency checklist and met with our clinical facilities and emergency management leaders for each of the facilities to consider our vulnerabilities, consider the climate modeling, and distill the most pressing concerns based on the data so far. And then finally in phase 3, we'll be starting to delve into those priorities to come up with a multi-year capital improvement plan, as well as a complementary plan for operations and emergency planning. So a few takeaways on the data and the process so far. I think first that our climate modeling included a near-term and a long-term time horizon. We looked at both 2030 and 2070. And this helped us understand what needs to happen right away and what could be incorporated into routine, ongoing capital planning and construction. We also looked at the probability of a certain event happening over the life of a building. What is the probability of a 100-year flood over the 50-year life of a building versus the 1% chance every year. We also modeled worst-case scenarios, and we found that this was helpful in looking both at the facility impacts and also the emergency management impacts, and reaching different stakeholders and helping us identify multiple ways to address some of these vulnerabilities. Finally, I think that mapping our region beyond just our building was really important, because even when one of our facilities seemed to look okay in a particular scenario, if we noticed that there were other hospitals nearby or a major transportation hub that would be underwater, we could imagine how we need to adapt to fill demand in those circumstances. And I liked Michael's comment earlier about specificity versus security. I think that one item that was always on our wish list is more detail in our public utility and transit system resilience, although, for various reasons, getting very specific data on that has been, a bit of a challenge at some points. In phase 2, as I mentioned, we completed the HHS Climate Resilient Facilities Checklist, and it was really helpful in spurring ideas about the different ways that you could approach resiliency and how it could be coupled with sustainability and even cost savings in a few areas. Some of the challenges that we had with this checklist were that, the answers to the checklist varied considerably based on who filled it out at each facility. And so this is why we eventually held meetings in phase 2 where we brought together our facilities managers, a clinician, and our emergency preparedness staff together so that we could really get the full picture. Another challenge was that, hospitals are very complex campuses. They're distributed over large areas, and so, needing to get the appropriate granularity through a checklist was difficult to do. So again, a static checklist alone was not sufficient to get what we needed. So I will end with a couple of considerations. I think as some folks have mentioned, I think it's really important to be clear about who the end user of the models will be. I think especially if it is healthcare facilities, if we're looking at a smaller or an independent facility, it really needs to be user-friendly and have a lot of data together in one place. I also think it would be helpful for facilities to receive a suggested menu of mitigation and adaptation strategies that might be useful based on their inputs into the model. I'd love to see more data on impacts to staff and their response and preparedness. And then finally, when we think about this, I imagine that most of us have inpatient care in our minds, but we always need to think about the full spectrum of inpatient and outpatient care, as well as the amount of biomedical research that can be at risk during natural disasters. So I'll leave it there. Thank you.
Thank you, Katie. I think this has been an excellent introduction to the practical aspects of integrated hazard, damage, functional, and population modeling. The presenters have generated a lot of questions. We only have a few minutes left, though, so we only have time for a couple. I tried to choose a few key ones and combine a few themes. Following the webinar, if you have questions that remain unanswered, you're welcome to follow up with the speakers individually, and we will post emails. Mike has been busy answering some questions on the side, which has been helpful, so thank you. So let me turn to one question from a listener, kind of a couple combined questions, and turn to really the practical side, and that would be, can you give specific examples of the kinds of modeling information for healthcare facilities that healthcare facilities would seek for disaster planning and response? And I think I can open this up to anyone in the group.
This is Katie. I'll just jump in and saying that, having climate predictions, we focused on sea level rise and storm surge, temperature, extreme precipitation, and heat. And having that at 2 different time horizons has been incredibly helpful. We are already using it in exercises, in HVAs. Our facilities directors are using it for capital planning, and so I think that even just that limited baseline data has already advanced us quite a bit.
And this is Kim. Let me just jump in a little bit, because I think one of the issues here is, there's lots of different kinds of modeling and data that they would need, as I talked about in my presentation. But the issue is always about how much they can actually use. And as Jamie and Michael talked a little bit about, each of these models, if you look at things like plume modeling or storm surge modeling, they all use sort of a little bit different parameters. What does a 1% probability per year mean for a 100-year flood when you're planning at a local level? And oftentimes that's different from the way, for example, earthquake probability is reported. And so, to be able to use all of these different things that are reported in different metrics in different ways gets very confusing for somebody whose background is not in that type of methodology. And so as we look at this, we need to think about modeling that the average college-educated person can utilize, not a specialist necessarily in your field.
Yeah, this is Jamie from the Hurricane Center. I agree. That matches my experience that during a storm, often I'm getting not only questions of where is the data, which you can solve that question in 2 seconds, but generally people needing help dissecting the data and interpreting the data. So there's a huge gap there to explain what the data is telling you.
Great points. Anyone else want to chime in on that? So let's move on to another question. If we're looking at the practical aspects of healthcare managers in disasters, and I guess the one we've been focusing on mostly has been hurricanes or flood events, one of the questions from the viewers was, how realistic are community evacuation times, and how do these play into hospital managers, and how can we get better information to hospital and nursing home and other healthcare provider to make the decision about evacuating versus sheltering in place?
So this is Jamie. I can answer the evacuation times, often called clearance times in my line of work. They're really realistic because we do all of this before the storm. So the data that I showed earlier is handed to federal, state, and local emergency managers who then run behavioral analysis to determine how a community might respond. That's how each community responds is likely different. Then they run a transportation analysis to ascertain how long it will take given the roads and how many people are asked to go. They do shelter analysis to determine how many people will go to a shelter or will need to go to a shelter so they can figure out the shelter capacity. There's a whole great big study that's predicated on the risk, the storm surge risk, that falls out of that, and then that contributes to a hurricane evacuation plan that's given to local communities.
Let me just add to that a little bit, because that is it's a general community plan. It is not necessarily for hospitals, because it's not just a matter of getting the people in the hospitals into cars and getting them out of the community. And so there needs to be more information and more work in terms of hospital evacuation, and getting that information to planners both at the state, local level that are helping to guide those decisions for local hospitals and nursing facilities and others, as well as to the hospitals and nursing facilities and other healthcare participants. If we just look back at Sandy, and when Zone 1 was evacuated, and the order came for Zone 1 to evacuate, hospitals in Zone 1 were told that they didn't have to evacuate. And so they then had to make the decision on their own about whether or not they were going to evacuate, because the healthcare people in the EOC decided that they knew better than what the modelers at the National Weather Service were saying, and made this, and we don't think we have to take that added risk for the healthcare system to evacuate the hospitals because it's dangerous. And yet then what happened was they ended up evacuating during the storm and after flooding. So there needs to be more work in terms of thinking about what it takes to actually evacuate hospitals and other facilities, other healthcare facilities.
Hey everybody, this is Mike. Sorry about that, Tom.
Yeah, Mike, can you do a quick?
Sure, I'll make it real quick. Yeah, and as both commenters and in my private comment that I put on there, Kimberly, great point that evacuation is not a no-risk protective action decision. And so sometimes you may be putting people at more risk if you have to put them out on the roads, and that's why there's other inputs that we can talk about timing and things like that. One of the questions offline was that question about evacuation time estimates. What Jamie talked about is really the gold standard. Great information is done there, close cooperation between the Weather Service and the Army Corps of Engineers. It gets a little more difficult if you're modeling evacuation times for communities or other facilities once you get inland, because it's really dependent on the assumptions. So that's where that for facilities, lashing up through your coalitions or whatever with your local emergency managers is your best bet, so you can get out ahead of that stuff.
Great, thank you very much. Unfortunately, we've run out of time. We've actually gone over 1 minute. I thought that was an excellent overview of the practical needs and activities of modeling. As a physician, I've always looked at the disaster from the on-the-ground perspective. Ultimately, everything we do with planning and preparedness and response has to do with saving lives and preventing injuries and illnesses. In this current environment of increasing climate and political threats, it's clear that as a nation we need to prepare for larger disasters and catastrophes by improving not just local, but regional healthcare response capabilities. And robust practical models that can be used for the planners and responders, I think, are a critical tool for that. This is going to take a lot of collaboration, not just across the scientists, but also we have to reach down to alternative science, just like epidemiologists and sociologists, as well as directly to work with the responders and planners to make sure that our models are both accurate and applicable. So thanks again to all our speakers today. I thought this was a great overview. I think this series is really generating a lot of discussion. I appreciate the questions from the audience. This concludes today's webinar, and thank you all for participating.